So today we are going to discuss about hemochromatosis. So what is hemochromatosis? It is actually iron overload in the body. There is large amount of iron accumulation in the body that is called as hemochromatosis. So now we will discuss its genetics. So it is caused by a hereditary condition. The gene responsible is HFE gene, which is related on chromosome 6p, and it is an autosomal recessive condition. You have to remember this. It is seen more commonly in males as compared to females, and it is caused by C282Y mutation. This is a very important point. It is caused by C282Y mutation. When you have to confirm that if the patient is suffering from hemochromatosis or not, then you are going to check for this mutation only in the patient. So this is a very important point, okay? And sometimes it might not be related to HFE gene, then it is non-HFE gene related, and other genes are involved in that case which are causing hemochromatosis. So that condition is called as juvenile hemochromatosis if other genes are involved apart from HFE gene, but mainly HFE gene is only involved. So now we will discuss how iron absorption occurs and how it is leading to hemochromatosis. So what happens is, duodenal enterocyte is the site where iron absorption happens in the body. Where it will happen? In the duodenal enterocyte. There you are going to have a divalent metal transporter 1, and that transport protein is the channel through which iron will enter inside. So after entering inside, then it is going to pass to another channel, that is ferroportin, and from passing through that channel, after passing through that channel, it will enter into the serum. That ferroportin channel is regulated by a protein molecule called hepcidin, and this hepcidin is in turn controlled by HFE gene. Okay, so this hepcidin has inhibitory effect on ferroportin, means HFE gene is the effect of hepcidin, which is regulated by HFE gene, on ferroportin is inhibitory, means it will decrease the iron entry into the serum. Okay, so now what happens in hemochromatosis? Means because of HFE gene defect, this hepcidin will not be there, or it is defective, and so there will be no inhibitory action on that ferroportin. So uncontrolled iron, because nothing is inhibiting it, and hepcidin is not there or it is defective, then uncontrolled iron will go into the bloodstream, uncontrolled iron, and then it will get deposited in various organs causing hemochromatosis. So this is actually hemochromatosis. You understood now how it happened? When it enters into via duodenal enterocyte, it by a protein channel, that is divalent metal transporter 1. After entering inside, it goes to another channel, that is ferroportin. Then from ferroportin it goes into the blood or the serum or the blood, okay? And that ferroportin is inhibited by hepcidin. And if HFE gene defect is there, then hepcidin will be defective and there will be no inhibitory action on the ferroportin. Uncontrolled iron will go into the bloodstream, which will then accumulate in various organs causing hemochromatosis. So now what are the clinical features you are going to observe? So liver, chronic hepatitis will be there. Mixed or macronodular cirrhosis you can observe in the liver. Mainly macronodular, but mixed can also be there. Hepatomegaly, swollen or enlarged liver will be there. Bronze metallic skin. Why? Bronze colored skin because of deposition of iron. Then pancreatic diabetes and also non-erosive, non-inflammatory arthropathy. That means joints. Joints will be affected. Non-inflammatory, non-erosive. You have to remember this point. So joints will be affected, and also hypogonadism. That is, the endocrine system will also be affected by iron deposition. Then comes the clinical features. You can see in this picture. These clinical features only you can see in this picture. Iron overload, how you can see the deposition of iron in the liver in the first picture. In the second picture, you can see bronze metallic skin, bronze in color, how the color has changed. This is because of high iron content only, okay? How are you going to diagnose it? So diagnosis is by serum ferritin. Serum ferritin, you can check for the level of serum ferritin. If it is raised, then you can understand that it is hemochromatosis. And you can also check percentage saturation of transferrin. But the best is you add both of them and then you check the level. Means serum ferritin plus percentage saturation of transferrin is a good indicator of checking hemochromatosis. Then what is the confirmatory test? That is, you have to check for C282Y mutation. I have already told you this point in the beginning slide. I have already told you, you have to remember this mutation. This is the confirmatory test, okay? So how are you going to treat hemochromatosis? You have to go for phlebotomy. What is phlebotomy? You will remove 1 unit of whole blood weekly. So you have to remove that iron in the body. So that 500 ml of blood is 250 mg of iron. So you have to remove that 1 unit of blood weekly. If that patient is unable to tolerate phlebotomy, then you can also give him subcutaneous desferrioxamine. What is desferrioxamine? It is a chelating agent again. It will bind to that iron and that will be removed from the body. Okay, you can give him this agent daily for 5 days a week. And the last method is liver transplantation. If none of these procedures work, last is liver transplantation. Okay. Now next slide you can see we have the hemochromatosis treatment, phlebotomy. You don't have to learn the details of it, but you have to remember that you have to remove 1 unit or 2 units of blood weekly, and 500 ml of blood will contain how much iron? 250 mg of iron. So you have to go for phlebotomy, and you can also go later when the iron level is controlled for maintenance phlebotomy, where 1 unit every 3 months. You have to remove that blood every 3 months, and you have to check for iron deficiency also. Means iron overload and deficiency, both should not be there. It should be normal limits. You have to check routinely for hepatocellular carcinoma because that person is prone for developing cancer. So that's it. Okay. So this is, and if phlebotomy is not tolerated, then you have other methods also. You can give him drug, subcutaneous desferrioxamine, and last is liver transplantation. That's it. This is all about hemochromatosis. Thank you.